Thank you very much, David. My experience is not as good as Craig's, to be honest, and I like to tell you why. So we all know that dislocation is probably the most annoying complication because usually it's our own fault and we cannot give the fault to anybody else. Dislocation is quite common, as we have just heard here, the data from the Nordisk registry, which shows you that there in Scandinavia, dislocation is the third most common reason for revision. In the Swedish registry, it's even more worse because it is #1 short-term complication requiring reoperation within the first 2 years. So incidence, as we have heard, is about 1% in revisions up to 10 times higher. What options do we have? We could use elevated rims, we can screw an elevated rim on it, we can use bigger heads to increase the jumping distance, or we can use, of course, constraint cups. But there are many, many concerns about constraint liners because they may lead to liner dislocation, early cup loosening, acetabular fracture, neck liner impingement, and so on and so on. So in total, we must say that constraint liners at the moment probably not the best solution, and at least we try to avoid it if it is possible. And even constraint liner, of course, can dislocate. So as we have heard, Bousquet introduced the concept of a dual articulation in 1976. You have heard about the concept of dual mobility, which is a fantastic and genius concept. And the results, as we have seen, are really good in the primaries. Here, 99.8% in more short term after 3 years. But our French friends published a lot of papers, as we have seen, with very low revision rates after implanting a dual mobility cup. Here, 25 years after a 25-year follow-up with just 8.02% aseptic loosening. Another one in patients under 50 years, also very, very good after 22 years, 77% survival rate. And you have heard also of this new specific complication, the intraprosthetic dislocation, which was first described by Filippo, and he published, to be honest, a little bit higher intraprosthetic dislocation rate as he has published on the soft cords that we have seen here. He recognized about 4%. The identified reason for intraprosthetic dislocation were cup loosening, blocking of the liner due to scar formation or arthrofibrosis. And another French group came to the conclusion that the current research has shown that the failure mechanism is affected by the surface topography of the femoral neck and in particular by the design of the mobile liner. We use dual mobility cups, of course, also in the endoclinic, in primaries, if a patient is in a higher risk for dislocation, incompliant drug abuse, dement, epilepsy, spastic patients. Here, for example, a spastic patient, 52 years, I used a dual mobility liner. And, of course, in many, many revision situations, and to be honest, more and more during the last 10 years. So some example, for example, if there is a loss of greater trochanter, where you have no stabilizing structures like the medius anymore, we use the dual mobility cup, or if the proximal femur is already gone, especially after infection, of course. So dual mobility cup is our standard in these special situations. But, and now I come to the bad news, dual mobility can fail. We have seen no failure in Craig's talk, but here we see a dislocation. Another example, a patient after one stage exchange, especially in our infection cases, we see this quite often, dislocation with a dual mobility cup inside. And after a while, over the years, I have seen so many dislocations in our morning session where we show all the x-rays from the day before. And I asked my colleagues to look after the results of our dual mobility cups, mainly in revisions, of course. So we did a retrospective study of about 500 patients that we implanted in 2009 to 2015. All, by the way, all our dual mobility cups, because we use it in revisions, are cemented. We looked after dislocation rate, cup loosening, and infection. Currently, we have seen more than 300 patients. We have some lost to follow up and some who are not participating. But this is the take-home message. Our dislocation rate is higher than ever published in the literature, 17.6%. Maybe we are bad surgeons, or maybe we have probably more worse situations in our hospital, but dislocation rate of almost 18% is quite high, despite the fact that we use dual mobility cups. More than 20% loosening rate in the our dual mobility cups. But do not forget, we use dual mobility cups in really desperate situations. So probably this is up to now not the ideal solution to use dual mobility cups in revisions. Probably there's one cup that I like very much and that I started to use recently, which is a combination of dual mobility cup and constraint cup. Probably it is a solution for the future. It has to